Well, hello, my name is Nilofer Azad, and I am a medical oncologist here at Johns Hopkins University at the Sidney Kimmel Comprehensive Cancer Center. I have been focused on taking care of patients with colorectal cancer for the last 15 years, and I'm very happy to be here today with Cancer Nursing Today as a roundtable to focus on colorectal cancer with two of my colleagues, Rachel Klein, who's a nurse practitioner who works at Johns Hopkins as well, and Fatemeh Youssefi, who is also here representing nursing that takes care of colorectal cancer. As a physician, when I'm trying to make decisions about what I'm going to recommend to a patient, the things I'm taking into account are the genetic background. So, the immunotherapy versus not if they have MSI, and then whether they have a mutation in these genes, and then their performance status, because can give triplet therapy with FOLFOXIRI, 5-FU, oxaliplatin, irinotecan as first-line therapy, because now we have data that patients may live longer if they get the 3 drugs versus 2 drugs, FOLFOX or FOLFIRI. That's especially true if they have right-sided disease or if they have a mutation in one of these genes. But I would love to hear from both of you when a patient is on FOLFOXIRI versus on either FOLFOX or FOLFIRI, how big is the side effect profile? So what are the side effects of FOLFOX, FOLFIRI? What happens when you give all 3? And how meaningful is that difference in terms of quality of life and side effects? Maybe Rachel, you can take that first, and then, but I'd love to get both of your thoughts on this from your experience.
Sure. So yes, I'd say since we've been using that triplet therapy, I would say for the last several years, or at least including it as an option for patients, we certainly, selection is important. We want to make sure that someone can withstand the side effects we're going to put them through. FOLFOX, as Fatemeh mentioned, is a doublet therapy of 5-FU containing a bolus and a continuous infusion that's done at home for 46 hours through a pump in the patient's Metaport or some sort of central line, in combination with oxaliplatin, a platinum-based drug that can cause significant neuropathy, fatigue, mucositis, which is mouth sores, and then FOLFIRI, which is previously the alternative first or second line therapy in alternating with FOLFOX, is the same 5-FU backbone, fluorouracil backbone with irinotecan, which significant side effects of the irinotecan would include drop in blood counts, so pancytopenias, diarrhea, mucositis. And then with all of these, we certainly can see the pancytopenia. We can see skin changes in the hands and feet. I've even seen mucositis in ostomy sites. That's unfortunate. That can be very uncomfortable. And so really when we combine these, we're sort of combining the intensity of both regimens in one. The benefit can be, I think, in many cases, when somebody has very symptomatic disease, right, or very bulky disease or large disease, and we really want an aggressive approach up front, I think that's when I might lean towards this regimen, not just for the overall survival benefit potentially, but also for the more immediate cancer symptom impact. So if someone's already having fatigue, if they're having near obstructive symptoms of their tumor, if they're having a lot of pain from the size of tumors, let's say in liver metastases that are bulky or that are stretching the liver and causing pain, or in the abdominal area, and the abdominal implants, so mental disease, I think we would be more inclined to choose an aggressive regimen if we felt that somebody's performance status was a 1 or a 0. So if someone's ECOG was a 1 or a 0, that means that they're up and about most of the day. They're performing their independent activities of daily living and by themselves. They're staying active. They're staying awake. Their nutrition is somewhat fulfilled. And so these toxicities, though they can be cumulative, we can always make modifications based on what toxicities arise, what side effects are giving them the most trouble. We can meet them where they are with supportive care medications to manage nausea, diarrhea, or mouth sores, or if we need to add, for example, a growth factor for white blood cells to help boost their neutrophil count through treatment. So we have a lot of tools to help manage these side effects. I think we've come a long way in that area, which is very nice compared to, let's say, the 90s. You know, we didn't have as many medications for nausea. We may not have had all the tools that we have today. So we set people up for better success.
So same here, you know, as Rachel mentioned, it all depends as where the patient's at with their performance status, right? When the decision as a providers, you make a decision, and to help us as a nurses to help them to go through this process. So if we know in the younger adult that if taking place of metastatic colorectal and you're doing the triplet regimen, it's important as a nurse to provide the resources for supportive measures. As Rachel said, we have a better nausea medicine now. We have a better way to fight the neutropenia or the growth factor, with the growth factor, to keep them on the same regimen. We are doing much better with the immediate lab result. We can, as an institution, if you can provide hydrations when they come for pump disconnect, if you can provide them with the tools so they don't get admitted to the hospital for the nausea, vomiting, and be able to use the institution resources to receive more antiemetic medications in post-chemotherapy, if you will. It is as the triple drugs, obviously, when you use the platinum, oxaliplatin, and irinotecan in that sense, and if you're using with the leucovorin 5-FU, that itself, so I think that we also intensify and tripling the side effects, if you will, be kind of tackling it and more intense. But if the patients can tolerate it, and if the performance status start and they don't decline, then I think we've given a promising for the good quality of life. Again, it's important to provide those resources for the patients. Supportive measures, basically.